In approaching our exemplars on the inflammation of the GI system, I found it necessary for myself to review the GI system. So I figured you guys did too, so that's what we're going to do in these first slides. So gastrointestinal system overview. Our objectives for this will be the student will have an understanding of the various functions of the GI tract from the mouth through the anus. The student will be able to apply knowledge of the learned functions into the provision of nursing care to include teaching for prevention of disease. The student will be able to understand various diagnostic procedures used to determine disease, and student will be able to correctly instruct patients on preparation for diagnostic tests, specifically the colonoscopy. This slide will show you the various structures of the GI system from the mouth all the way through the anus. What I'd like you to do right now is put this slide on pause and take a piece of paper and a pencil or an ink pen, I don't really care. But just take a writing utensil and a piece of paper and draw for yourself a cursory diagram of the GI system from the mouth all the way through to the anus. Do not proceed with this PowerPoints in this presentation until you've done that, because I think that's going to really help you have a grasp of where things are and what's happening in that area. So put this on pause and do that diagram. You don't have to make it look pretty. You don't even have to make it look like the right shape. Just do it, okay? We're going to talk about the cursory functions of the GI system. And what that means is I am not going to tell you about all the functions. There's just so many. There's over 400 in the liver alone, okay? So we can't go through all of them. But we're going to get a cursory overview of what is supposed to happen where in this system. It's with that knowledge that you can help, well, it should help you understand the problems a patient may develop in certain areas, and also help you understand the diagnostic procedures that are used to evaluate and the lab work that is a huge part of diagnosing problems and evaluating if our treatment is working. So let's start with the oral cavity. Of course, it chews. We chew, begins that breakdown process. You take that toast, chew your toast, you're starting to break it down. Saliva is the main secretory contributor in this stage. A lot of other things are happening, but mainly you're chewing and adding saliva, starting the breakdown process. Then it goes through the esophagus, and this is where it moves food and fluids from the pharynx to the stomach. We have two esophageal sphincters. One is the upper esophageal sphincter. Why do I say sphincter? It's sphincter, or UES. That prevents air from going into the esophagus during respiration. And it didn't say this in the book, but I'm kind of imagining, you know, if you ever kind of inhale something wrong and you have that coughing fit that you think you're never going to recover from, I think it's because that sphincter may have allowed fluid, little droplets of fluid to go into our lung. You know, kind of works in reverse. Didn't say that in the book, but that's kind of what I think happens when we do that. The lower esophageal sphincter, if that doesn't work, if that kind of flaps open, the patient's going to have GERD, that reflux. Ugh, horrible stuff, that GERD. The stomach is the food reservoir where digestive processes begins. It secretes hydrochloric acid and pepsin, which is a digestive enzyme. So you can see that combination of digestive enzyme and actually hydrochloric acid. It's going to really start breaking down whatever's in there even more. It mixes and churns the food, mixes it with gastric secretions to form what is called chyme. And I'm like, yeah, that's what that's called. I remember hearing about that a long time ago. So that's the stuff that it ends up breaking down into. In the stomach, intrinsic factor is produced. Please remember this, because it may not be on a test. I'm not telling you to remember it because it's going to be on a test. Okay, I'm going to tell you to remember it because the absence of this intrinsic factor is what causes pernicious anemia, okay? Intrinsic factor is required to aid in the absorption of vitamin B12. So if that is lacking or missing, those are the patients that have pernicious anemia. So try to remember that just to help you understand that type of anemia should you ever come across a patient that has that. This is a schematic drawing of the pancreas, liver, and gallbladder. I want you to just really look. You see where the diaphragm is. Underneath that, tucked under that, is that liver. And then the gallbladder is kind of behind the liver. Then you have the hepatic ducts, all these different ducts that come out. And so bile has to go through those ducts, etc. You don't need to memorize this, but I just think it was a really good schematic of this area of our GI tract. The tail of the pancreas is in there. They say it looks like a fish. I guess it kind of does, but that's consisted of the head, the body, and the tail, okay? And that is, of course, where insulin is produced. And then you have the duodenum, which is the lower part there. So just kind of be familiar with where things are located and in what order they're located. The pancreas lies behind the stomach. It consists, as I said, of the head, the body, and the tail. They have both exocrine and endocrine cellular bodies. The exocrine cellular bodies provide the digestive enzymes that are needed to break down carbohydrates, fats, and proteins. The endocrine cellular bodies consist of those islets of Langerhans, and that is where our sugar processing agent is. That's our sugar factory, okay? The alpha cells in the islets of Langerhans form the glucagon, which helps us break down glucose, and the beta cells are the source of the insulin. So you can see if there's a deficiency of the beta cells, we're going to need insulin. If there's a deficiency of the alpha cells, we probably can get by with oral agents, okay? So just think of the islets of Langerhans as the sugar factory, decreasing it, taking care of the sugar, I guess. The liver and the gallbladder is going to be kind of next. The liver is the second largest organ in the body. Okay, what do you think the first largest organ is? You going to get it right on Jeopardy? The answer is skin. Yay, if you got that right, clap yourself, clap your hands. But anyway, the liver is the second largest organ in the body. It performs over 400 functions, and the three major categories it does these functions in is storage, protection, and metabolism. It stores minerals and vitamins such as iron, magnesium, A, D, E, and K. So it stores those. It provides us protection, the phagocytic Kupffer cells, which I remember hearing about those as well. Those engulf harmful bacteria and anemic red blood cells. It takes care of the bad stuff. And it also detoxifies potentially harmful compounds such as drugs, alcohol, medications, chemicals. Very important function. The metabolism it provides, it breaks down amino acids to remove ammonia, which is then converted to urea, which is then excreted by the kidneys. So you see how vital that liver is on the most very basic of levels. The liver also secretes bile, which is essential for the breakdown of fat. And the gallbladder, that would actually be the gallbladder. I'm sorry. The gallbladder secretes bile, which is essential for the breakdown of fat. And the reason I pause is because if you've heard of people that have really bad gallbladder attacks, it's, you know, if they eat the wrong thing, if they eat too much fat, they'll have the gallbladder attack and they have to crawl in the bathtub at 2 in the morning to get through the pain until the doctor's office opens. So that is the gallbladder that does that. It collects, concentrates, and stores the bile, which it then releases into the duodenum via that common bile duct when fat is present. So if you've got a gallbladder that's not behaving and doing its job, that fat cannot be processed. They get pain. It's the man's version of childbirth, I understand, where it's the pain equivalent to childbirth, which I don't know. I've never had the gallbladder attack. Can't really say, but I've heard that. Okay, cursory functions of the small intestine. It is the longest and most convoluted portion of the digestive tract. It's amazingly 16 to 19 feet in length, which that is that's all inside our abdomen. It's amazing. It's got the duodenum, the jejunum, and the ileum. It has three main functions. That would be movement of the product, mixing and peristalsis, moving it through the system. It also is a digestive function with secretions of surface look at the circular folds right down there, circular folds of mucosa and submucosa, which increase the surface area for digestion and absorption. If you remember, we talked about the placenta and how it has all those cotyledons, increasing that surface area for blood oxygen transfer. This is similar in the sense that those circular folds of mucosa and submucosa provide a greater surface area so that more digestion and absorption can happen. So, of course, the third main function is absorption of nutrients. It takes an average of 3 to 10 hours for contents to be passed by peristalsis through the small intestine, which, you know, I watch ID. Okay, I'm an ID addict. I admit it. That's why I don't date. I think anybody's going to kill me. But they always evaluate the stomach contents and they can determine how long ago the killing happened. So, yeah, 3 to 10 hours. That's a baseline. All right, the large intestine is about 5 to 6 feet in length. It is lined with a different type of epithelium, those columnar epithelial cells, and they also have absorptive and mucus cells in them that aid in the movement and digestion. Okay, and absorption is big. You get into the cecum, and then you get to the appendix. And as we know, the appendix, I wonder what it used to be known for, what they used to do with it. There's no known function for it now. It's just kind of there, and it'll get in trouble and, you know, get inflamed and burst on us, and then we can die. So seems like the only function it has is to potentially kill us. But there must have been something. If one of you can figure it out, let me know. I'd love to know. I might actually research that, but it doesn't have a function in today's world. The colon, of course, we've talked about that in regards to cancer. We have the ascending colon, then the transverse colon, the descending colon, and then the sigmoid colon. And you should be able to kind of picture in your mind those different areas from our cancer talk. And where colostomies, remember we talked about colostomies, where would those be located based on what type of cancer they have? So just kind of a reminder, a check back. Then, of course, it gets to the rectum, the anal canal, and then the anus. Functions of the large intestine is movement of the product, which doesn't even look like food anymore, but an absorption, of course, we're still absorbing nutrients in the large intestine, and of course, elimination of that which we do not need. Yes, there are effects of aging on GI function, and I'm going to refer you to the chart on page 1088, which is chart number 52-1, because it is a very thorough list on the specific areas. I did not want to recreate PowerPoints for that since you can easily look it up. But one of the main things it mentioned was the decrease in gastric hydrochloric acid, which leads to a decreased absorption of essential minerals such as iron. So the older people have a risk of anemia because of that. All right, let's go into the assessment of these patients with potential GI problems. The purpose of the health history is to determine the events related to their current health problem. What brought you in today? What's the concern? What is it that's worrying you or bothering you? And let them describe it. Put it in their words. Put it in quotes in their words. That's the initial reason for the visit, is states this, then this, and this, and this. Put it exactly as they state it. And then we want to focus our questions on any changes in their appetite, in their weight, and in their stool. Has it gotten gassier? Are they formed? Are they constipated, or are they loose and watery? Have they changed? Are they ribbon-like, R-I-B-B-O-N, ribbon-like stools? That can indicate that there's a narrowing of the canal, of the intestinal canal. So be very thorough in that assessment in these areas of appetite and weight gain or loss. Assess for any pain. Certainly, we want to make sure that we're very thorough on identifying what pain they have, because that can help us, help the physician and the provider and us determine what might really be the problem. What medications are they on? Are they on aspirins every day, NSAIDs? These can predispose a person to peptic ulcer disease and GI bleeding, so it's important to get that medication history. The long-term use of laxatives or enemas can cause a dependency, and this can then result in a rebounding constipation and then in electrolyte imbalance. So it's really important to see if this is something that they have gotten themselves dependent on and why. What started this journey into laxative dependence? Are they a smoker? Do they chew tobacco? Those will increase their risk of, you got it, cancer. Well, you don't have it. That's not what I meant, but you understand, cancer. Travel history, if they especially have diarrhea. Where have they been lately in the last month? See if they've been out of country to a country that has problems with certain bacteria. What is their nutrition history? Has they changed their diet in any way? What is it they don't ever eat? Do they not eat vegetables or fruits? What do they dislike? What do they like? What do they eat a lot of? Are they McDonald's everyday kind of a person, or do they cook for themselves? You're going to get different results in your health based on that answer. Do they have any unintentional weight loss? Very important. We've learned that with cancer. That's one of those risk factors. If you remember, the 7 risk factors for cancer would be weight loss that they didn't plan. Alcohol and caffeine consumption. These are associated with gastritis and again, peptic ulcer disease. This kind of bums me out a lot. The caffeine in the morning. Yeah, I'm not giving that up. I'm sorry. I might wine at night. I'm okay. I'm over 21. All right, objective assessment. Okay, this stuff you've got to practice doing. Do it on your roommate, your boyfriend, your girlfriend. Do it on a puppy dog, a stuffed animal is what I was trying to say. But practice your objective assessment on the GI patient. Inspect the mouth, look inside. Do they have lesions? Are there sores that prevent them from chewing and eating properly and breaking food down? Is that the initial problem? This is going to sound weird, but yeah, I had a cat that I had to have put to sleep. Bless her heart. God, I miss her. Name's Callie. She's my little talker. She and I would solve all the world's problems because she chitty-chatted and we had a good conversation. But she ended up with severe renal failure. And her renal failure was her symptom of that was lesions in her mouth. Her kidneys could not break down the product that whatever was going on in there. And so she had oral lesions, and I had to have her put to sleep because she couldn't eat. You talk about breaking your heart, okay? But that's, it couldn't be fixed. We tried everything. So look inside the mouth for lesions and signs of redness, irritation, and do they do good oral hygiene, okay? Then let's work down to the abdomen. We want to be systematic in our assessment of the abdomen. I would think you guys know these initials, but I wanted to make sure. The right upper quadrant, go from the right upper quadrant over to the left upper quadrant, then down lower left lower quadrant, and then right lower quadrant. Be systematic about how you do your assessment. The way you do it the first time, do it that way every time, unless you figure out a way to do it a little better. But do it systematically. Always, always, always do not touch the abdomen first. We inspect. We do not want to disturb or create abdominal gastric movements by palpating. So we must first look and inspect. Look right below here where it says bulging, pulsating mass in the abdomen. If you're inspecting and you see that abdomen doing some kind of a moving thing, and she's not pregnant, okay, if she's pregnant, it's probably the baby. Okay. See, everything goes back to OB for me. You know that by now. But if she's not, if it's a man or if it's a woman not pregnant, if there's a bulging mass that's pulsating, do not touch it. It could be an abdominal aortic aneurysm. Notify the provider immediately. Okay. So always look first. Then we get that stethoscope out and we're going to auscultate. And you're going to auscultate from the right upper to left lower to right lower. Do it in that system. Look or auscultate. And you're auscultating for, of course, bowel sounds. That's the most obvious. But you're also going to auscultate for bruits. And you look at that last point I added there, which is hearing a bruit, which is a swooshing sound. If you hear that over the abdominal aorta, it usually indicates the presence of an aneurysm. So do not percuss or palpate. Again, do not touch it. Notify the healthcare provider. So that's why those two are done first, to identify, to first not interfere with bowel movement that's there. We don't want to add our impulse onto that, but also to prevent the risk of damage, of hurting our patient. The last two, percussion and palpation, your book is saying that those are done by the advanced practitioners. You know, I don't necessarily agree with that. Percussion is simply putting your finger down and tapping your finger, and you can hear if you're over fluid versus over solid tissue. It's actually kind of fun to do. And you'll hear different sounds. And then palpation, you can do gentle palpation. Definitely do not do deep palpation. That would be the provider's responsibility. But you can do very gentle palpation, again, in the right upper, left, lower, right, lower quadrants, to see and watch that patient's expression. What you're looking for is her or his reaction to that light palpation. Does it hurt? Is she starting to guard? Does she start to look like, oh, this is not going to feel good where she goes next? So get used to doing that light palpation. If they do have pain in one area, do not push deeply. That you would record, you would chart that, and you would notify the provider that you felt pain in the right upper quadrant. I just did gentle palpation and I could tell it was hurting, so I didn't do anything deeper. Okay? How do we diagnose things? And we're going to start with lab work, and then we'll talk about imaging type things. But first, the serum tests. CBCs would be done. Of course, we're going to check for anemia and infections. GI bleeding is the most frequent cause of anemia in adults. Okay, so if you have an anemic patient, it's essential that we evaluate the GI system. If they haven't had a colonoscopy, they need one to check for bleeding in the GI tract. It can be associated with GI cancer, peptic ulcer disease, diverticulitis, or IBD, inflammatory bowel disease. Okay. The prothrombin, that does not mean patient, it means prothrombin time would be done because the liver is the main site of all proteins involved in coagulation. So that prothrombin time is very useful in evaluating the level of these proteins. So if you have an abnormal level, a decrease in that level, you can suspect the liver is being a stinker. Elevated serum amylase and lipase may indicate acute pancreatitis. So look at your laboratory. This is where that differential, you know, we do CBC with diffs and CBC with diffs, and we always ask you what the hemoglobin, hematocrit, and white count are. There are other things on that diff, and it's the serum amylase and lipase. The AST and ALT are on there, and I've always looked at them, but it was good for me to review these. I knew it indicated issues with preeclampsia going into severe eclampsia, but this was a great review for me. But the AST is aspartate aminotransferase, and the ALT is alanine aminotransferase. And these are two enzymes that are found in that liver and other organs. So you can see where if we have a patient who is getting into the eclamptic area and that liver's going off, yeah, we're going to have an abnormal AST and ALT. And of course, it would, again, I refer to pregnancy, but any liver disorders any disorders that involve the liver, you're going to have an elevation in the AST and ALT. The highest conditions, the conditions where they elevate the highest are in conditions that cause necrosis, such as viral hepatitis and cirrhosis. Those are going to really elevate the AST and ALT levels. Electrolytes, many of these are altered in GI dysfunction, so we want to look at them. Examples are low calcium. Calcium is supposed to be absorbed in the GI tract, but in a dysfunctional GI tract, it may not be. So you're going to get a decrease in your electrolyte and your calcium level. The low sodium and potassium may occur because of excessive vomiting and diarrhea from whatever cause of the GI tract. Bilirubin is the primary pigment in bile, and it's normally excreted by the liver and the biliary system. So if you have elevated bilirubin, you can suspect liver problems. Ammonia measures liver function as well. It's normally used to rebuild amino acids or is converted to urea for excretion. So if you have an elevated ammonia level, that could indicate that the liver again cannot function well, and you can suspect cirrhosis or fulminant hepatitis. That's pretty severe, pretty far advanced. Oncofetal antigens, the ones that they referred to in the book were CA19-9 and CEA. These are used to diagnose cancer, monitor the success of cancer therapy, and assess for the reoccurrence of cancer in the GI tract. And reflecting back on our prostate lessons, we learned about that PSA, that is a test for not really diagnosing prostate cancer, but monitoring the success of therapy. So this is the same with these antigens. It did say in the book it's used to diagnose cancer. I think it's more likely used to monitor success and assess for reoccurrence of cancer, because cancer is actually diagnosed by, remember, we do a biopsy. That's the actual diagnosis for cancer. All right, urine tests. Amylase is elevated in pancreatitis. Urobilinogen is elevated in hepatic and biliary obstruction. Stool test is the FIT test, which is fecal immunochemical test. It is not guaiac based. And what that means is those patients don't have to go on a special preparation diet to foods to avoid, because there's no guaiac to be interfered with. The yearly FOBT, which is, I knew what this is, fetal occult blood test / is guaiac based, and it's recommended to detect colorectal cancer. These patients must avoid certain foods prior to the guaiac-based test, such as raw fruits and veggies and red meat. Anticoagulants and NSAIDs should also be DC'd for 7 days before testing on the guaiac-based test. And then there's C-Diff. Goodness, we've heard of this one. These patients are usually symptomatic. They have usually been on a prolonged antibiotic therapy, and it's especially prolific in older adults. It depresses the natural intestinal flora and causes an overgrowth of the pathogen. The bacterium release a toxin that causes colonic epithelial necrosis, and this results in the severe diarrhea that is easily transmitted from person to person. Hand washing and contact precautions, please. You knew that. Then we're going to talk a bit about imaging assessments. There's a ton of them written in the book. I am not telling you about all of them, but I pulled some out that I thought were kind of the more main ones to use. We have the plain X-ray films of the abdomen. Those can look for masses, tumors, strictures, or obstructions to normal movement of the bowel. Acute abdomen series, you may see that be ordered a lot. And that's done for severe abdominal pain, and it includes a chest x-ray, supine abdominal film, and then an upright abdominal film. And what it's kind of looking for is the bowel perforation, which would be one of the most likely causes for that acute abdomen. Upper GI radiographic series. This consists of an x-ray visualization from the mouth to the duodenal-jejunal junction. Go back to the other slide to see where that is. It detects disorders of the structure, the function of esophagus, stomach, or duodenum. The next would be small bowel follow-through, and that would be where it continues that upper GI from the duodenal jejunal junction all the way through the small intestines. Just keeps on going. The double contrast barium enema exam is otherwise known as a lower GI series, and that is an X-ray of the large intestine. The American Cancer Society recommends this test every 5 years in persons older than 50. Or we have options: colonoscopy every 10 years, or the flexible sigmoidoscopy every 5 years, or the CT colonography every 5 years. And that's a virtual colonoscopy. They prepare the same to empty the bowel, but then it's just visualized externally. However, if they do suspect polyps, that they see something, guess what? You gotta go in. So you might as well just get the colonoscopy and be done with it for 10 years. That is my personal opinion only. How do we do a colonoscopy prep? You're going to learn that. You're going to teach your patient this someday in your life. It might be your own mom or dad. It could be yourself. But you're going to have to know this one day. So you might as well learn it today. Colonoscopy is the endoscopic exam of the entire large bowel. It is the gold standard for detecting GI cancers. Patient prep. The patient is to stay on clear liquid diet the day before the scheduled colonoscopy. The purpose is to get fluid stuff instead of firm, thick stuff needing to be expelled. They must avoid red, orange, or purple beverages because that can discolor the stool that's left behind if there is any and interfere with the results. They must drink an abundant amount of Gatorade to replace electrolytes that they lose when they do all this stool cleansing stuff. They need to be NPO except for water for 4 to 6 hours before the procedure. Avoid aspirin, NSAIDs, anticoagulants, and antiplatelet drugs for several days before the procedure. They may, probably going to be required to drink an oral liquid prep for cleaning the bowel. Go Lightly is the one that I've heard of. That's what I've taken. And that's done the day before. Another thing that people can do, which I chose to do the second time I had to have one because my first time I was one of the 25% that didn't get cleaned out well enough, so I had to have it repeated. I also did smooth move tea. That'll help clear it out. So, but Go Lightly generally will do it 75% of the time. Do not use the Go Lightly on older adults because it may cause excessive fluid and electrolyte loss. Not sure what they do then. Honestly, I'm like, what do they do to get all that out of there? I don't know. Smooth move tea, maybe. And drink it quickly to avoid nausea. I don't know that that's possible. You're going to get nauseated. You can do the first 4 glasses quickly, and then it's like, ugh. All right, your last slide. Question: how long is the entire gastrointestinal system in a mature adult? How many feet long is it? That's your assignment to find that answer. I hope you enjoyed this.